as you understood, of course, weight loss and exercise are the cornerstone of treatment of MASH, but there's a lot of new treatment approach, pharmacologic approach, with I will deal with within the next 15, 20 minutes. These are my disclosure. So first of all, I will focus on patients with so-called at-risk MASH, so NAS4 and F2, F3. We can discuss about cirrhosis during the discussion. This is the outline. So the very next picture that has already started in the US, but not in the rest of the world, and what will be available in the future, the pipeline. So regarding the next future, we have two phase 3 studies. The first one with resmetirom. So resmetirom is an oral agent administered every day, selective thyroid hormone receptor beta agonist without extrahepatic effect, with many effects such as reducing lipogenesis, reducing LDL cholesterol and triglyceride, increasing mitochondrial biogenesis, beta oxidation, lipophagy, autophagy, and also antifibrotic effects. So this is the phase 3 randomized controlled trial that has been published last year in the New England. And you can see that the two histological endpoints defined by FDA for conditional approval, that is NASH resolution and fibrosis improvement, were met with the drug at 52 weeks. So it was a very simple design, placebo against two doses, 80 milligram and 100 milligram. And MASH resolution was obtained in 30% and 26% of patients with resmetirom, and fibrosis improvement in 26 and 24. Now, in terms of safety, the main side effect is diarrhea at the starting of treatment in around 30% of patients, but then that resume during the treatment. Nausea, no serious adverse event. So this led to the first FDA-approved treatment in March 2024 in the US under the name of Resdifra. And this drug likely should arrive in Europe and in the rest of the world by the end of this year. Another drug is a well-known drug, semaglutide, GLP-1 receptor agonist, already used in treatment of diabetes with pleiotropic effects. It's an injectable drug once a week, and it has effect not only on the liver, but many other organs, including the brain or the heart, the kidney, pancreas, and muscle. This has been published very recently, a month ago, also randomized controlled trial, only one dosage, 2.4 milligram. That is a dosage not for diabetes, that is 1 milligram, but for obesity. And longer duration, 72 weeks. And as you can see, NASH resolution was achieved in 63% of treated patients versus 34 in placebo, and almost 37 in terms of fibrosis improvement versus 22 in the placebo group. And both endpoints were met and significant. In terms of safety, there are class effects of GLP-1 receptor agonists that are well known by the diabetologists, mainly nausea, diarrhea, constipation, and vomiting in around 30%, 20 to 30% of the patient, and they usually resume after a few months of treatment. If you look at the additional metabolic benefit of these two drugs, both have effect on the lipids, as I already mentioned with resmetirom, but resmetirom has no effect on diabetes, using HbA1c as a surrogate, and no weight reduction with this drug, whereas this is the case with semaglutide. Now, let's move to the pipeline, so what we can hope in the future. So I will give you a brief overview of what is going on of the 2B studies. So as you know, MASH has a very complex pathophysiology, but there are many metabolic, or let's say therapeutic targets, and mainly metabolic. So incretins, the flagship is semaglutide, and incretins are hormones that are insulin synthesizer, and I will discuss tirzepatide and survodutide. We also have FGF21 that also are hormones involved in glucose homeostasis, insulin sensitivity, and lipid metabolism. There are several of them: efruxifermin, pegozafermin, efimosfermin. Then also lanifibranor, that is a PPAR agonist, and denifanstat, that is a FASN inhibitor. So let's start with lanifibranor. It's a pan-PPAR agonist with effect on steatosis, inflammation, and fibrosis. As you can see, this study has been published now 4 years ago, 24 weeks, and you can see that at both dosage, 800 milligram or 1,200 milligram, both endpoints were met. NASH resolution, that was a primary endpoint of the study, but also fibrosis improvement after 24 weeks in 42% of patients versus 24% in the placebo, and this was significant. In terms of safety, again, mainly diarrhea, but let me draw your attention to the possibility of weight gain and peripheral edema in a subset of patients, especially at the high dosage. Now, efruxifermin, this is a FGF21 agonist, as I already mentioned, with pleiotropic effect. I don't have time to go into detail. This is the structure of efruxifermin. It's an injectable drug. The previous drug was an oral drug, but most of the drug I will present are injectable, and this is once-a-week administration. These are the histological endpoint, and you can see at 24 weeks, again, NASH resolution was very high in the 50 milligram group, 76% versus 47% and 15% in the placebo. So was fibrosis improvement, 41%, not much different from the lower dosage, but higher and significantly higher than the placebo. These are recent data that have been presented last year at the EASL meeting as a late breaker with a long-term follow-up at 2 years. And there is still an improvement in fibrosis, as you can see, until 75% in the high dose group. In terms of safety, quite similar to what is observed with GLP-1 receptor agonists, mainly gastrointestinal effect, diarrhea, nausea. Pegozafermin is another FGF21 agonist with pegylated, so longer half-life. And there was 3 dosage, 2 dosage once a week and 1 dosage every 2 weeks. And you can see that the placebo is very low. It's the lowest ever in every MASH study, 24 weeks. And MASH resolution was obtained in 37%. And fibrosis improvement was, as usual, less, around between 20 and 27% versus 7% in placebo. And this was significant. Safety very similar to what I've described with efruxifermin. Now, efimosfermin is another FGF21 agonist. This one has a much longer life because it's administered only once a month. It's from Boston Pharmaceutical. And you can see this has been presented at the last MASLD meeting, 24 weeks. High rate of NASH resolution, 68% versus 29%, and fibrosis improvement in 45% versus 21%, both significant. Safety, as usual, in 20 to 30% of patients with nausea and diarrhea. Now, what about the incretins I mentioned? So tirzepatide is a well-known drug used in obesity. It's a GIP-GLP-1 dual agonist with increased effect as compared to GLP-1 receptor agonist in terms of weight loss, with weight loss in the magnitude of 15 to 20%. And you can see that in this study, at 52 weeks, there were 3 dosage, 5, 10, and 15 milligram. There was a dose effect for NASH resolution, 62% versus 10% in the placebo. This was the primary endpoint of the study, and this was highly significant. In terms of fibrosis, there was a difference with higher rates of fibrosis improvement, around 50%, no real dose effect. And this was a secondary endpoint, and it was not significant. In terms of safety, was pretty much the same as compared to GLP-1 receptor agonist, with mainly digestive side effect. Now, survodutide is another dual agonist, this time with glucagon, and they have a synergistic effect on weight loss and also a fat-burning effect in the liver. This is an injectable treatment once a week developed by Boehringer Ingelheim. And you can see the histological endpoint. The primary endpoint to get was NASH resolution that was achieved in 62% of patients in the intermediate dosage versus 14% in placebo. Fibrosis improvement was superior to placebo, but not significant. Safety, very similar to tirzepatide. But just a warning that around 20% of patients had to stop the drug because of side effects. And this is likely because the increase in dosage was maybe too fast than it should be. Last but not least, denifanstat, so a fatty acid synthase inhibitor inhibiting D and L. And you can see the histological endpoints. So NASH resolution in 26% versus 11%, but no fibrosis improvement. I mean, there was a fibrosis improvement, but not significant. In terms of safety, this is quite different from the other drugs I've mentioned. And alopecia was observed in around 10% of patients. That might be an issue for this drug. Last but not least, this has just been published about a week ago. Dapagliflozin is a SGLT2 inhibitor that is used in treatment of diabetes. The way it works is inducing glucosuria to control glycemia. And this study is from China, a randomized control study published in the BMG. And there was a subgroup of patients with F2, F3, where the FDA criteria were used, and you can see NASH resolution was obtained in 23% versus 4% in the placebo, and fibrosis improvement was higher than NASH resolution, 56% versus 28%. In terms of safety, was very safe, and this is already well known in the diabetology community. So sorry for all this catalog, and let me try to recap and to summarize. So I think you need to look at the different drugs and a different study in terms of number of patients, and you can see they go basically from less to 100 to almost 300. But the duration of treatment, of course, is critical if you look. And then also, what is quite striking is the difference in placebo. As I already mentioned, in the pegozafermin study, the placebo was really low, 2%. But for instance, in the efimosfermin study was 30%. So highly variable from a study to another. Now, in terms of fibrosis improvement, again, you can see same comment for placebo. Again, very low in most study. And you can see that they were not all significant. Those with 24 weeks were significant. Dapagliflozin was significant, but was not the case for survodutide, tirzepatide, and denifanstat. And of course, what also is important, I mentioned the efruxifermin data that are not published yet to my knowledge. When you have a longer duration of treatment, that is also probably important for fibrosis improvement. So before concluding, I would just like also to summarize the additional metabolic benefit of this drug. And for instance, denifanstat had no effect on lipid, was even could increase some of the lipid, no effect on A1C and weight, and alopecia as a side effect. Pegozafermin has an effect on lipids, and actually it's used for severe hypertriglyceridemia, but no effect on A1C and weight. Lanifibranor has a slight effect on A1C, also on lipid, but can lead to weight gain. Dapagliflozin has effect, of course, on A1C and lipids, but not on weight. Same for efimosfermin and efruxifermin, but drugs like dual agonist tirzepatide have an effect on lipid, A1C, and weight, and the same for survodutide. So this is also important to take into account when you're treating your patients with a holistic approach. You're not only treating the liver, you're treating the comorbidity. So as I've shown you, the future is bright. So resmetirom is FDA approved in non-cirrhotic MASH in 2024 in the US and likely approved in 2025 in Europe and the rest of the world, hopefully. Semaglutide likely to be FDA approved also in 2025 and in Europe probably in 2026. Many other drugs with promising result and additional benefit on comorbidities. There are many unanswered questions and future challenge. Will current histological endpoint translate into clinical event? How will trial result translate into real-world practice, given the high screen failure rate? So many qualifying patients were excluded from trial, compliance to treatment, duration of treatment, assessment of response to treatment. Do we need to use surrogates? And finally, combination or a la carte treatment.